Throughout my many years of physician education, I would constantly hear from the physicians in the audience, I know how to take care of patients, but I do not know how to transition that care into a level of care, meaning inpatient versus observation. It is because of that I tried to come up with a simple methodology to teach to help with documentation and the role it plays in defining the acuity of inpatient or observation. In reality, there are 4 simple requirements for high-quality documentation. Number 1 is accuracy. The key factor is to tell the patient's story and to tell it as it occurs with as much detail as possible that is pertinent to what is going on. And that leads to the second requirement, and that is precision. And the documentation must be precise without any errors or exaggerations or deficiencies, and it must be consistent. The third element is that of timeliness. It is important to get the documentation done as quickly as possible because it can have an effect on the level of care and what goes on in the patient's future as far as possibly going to a skilled nursing facility or other outcomes. That is simply defined as clarity. And copy and paste is something that is used and abused very frequently. But on the other hand, if copy and paste is going to be utilized, there's a third word that goes along with it, and that is edit. So let's talk a little bit about what to document. Let's start with a chief complaint. There are all sorts of variations as to how a chief complaint is documented, but in essence, it is a concise statement of the symptoms that cause a patient to seek medical care. And using the patient's own words is a very good way to start. And then there is the primary diagnosis. All diagnoses that impact the patient's care, evaluation, and treatment make up the primary diagnosis, and each one of them should be relevant. What else to document? I do know that many of the electronic medical records will pull in the past medical history, but it's important to review it before you just accept it. Coexisting acute conditions are generally listed, but be careful not to use the term history of if the disease is actively being treated. Many times I would see history of breast cancer on tamoxifen. Well, tamoxifen is a statement of something that is being treated, so it would not be history of, it would be breast cancer on tamoxifen. One can list chronic conditions, and we could get carried away with that when we pull in that information from the electronic medical record. Realize that treatment must be monitored, evaluated, and it must be actively being treated. And at the end will be a complete assessment and plan, and that's usually in the form of a problem list, and this will be addressed later on in this presentation. There are factors to be considered when making the decision to admit, including such things as listed below. And this comes from the Medicare Benefit Policy Manual, Chapter 1, Section 19. There are essentially 4 bullet points to this. The first one is the severity of the signs and symptoms exhibited by the patient. Well, that comes from what would be the beginning of the history of the present illness. Number 2 is the medical predictability of something adverse happening to the patient. What does that mean? Based on the condition of the patient and the way that they present, what can possibly go wrong? And that's how we think when we admit patients. What could go wrong with these patients based on that presentation? These first 2 define the acuity. Then number 3, the need for diagnostic studies that appropriately are outpatient services, and that just means that their performance does not ordinarily require the patient to remain at the hospital for 24 hours or more to assist in assessing whether the patient should be admitted. And one of the ways to look at that is if you've probably seen denials that say, and these services could have been provided in a lesser setting. That just means that the acuity has not been well defined, and these outpatient services will reflect on the fact that this could be done at a lesser level of care. And lastly, the availability of diagnostic procedures at the time, when, and at the location where the patient presents. And at rural facilities, many times these diagnostic procedures are not available at that facility. And the information presented here is based on traditional Medicare and the regulations that exist. But in summary, there are 5 key pieces of documentation for Medicare cases and determining medical necessity of inpatient. Now realize that this using Medicare as a standard should also follow through with the rest of the payers. Those 5 elements are the medical history, current medical needs, severity of signs and symptoms, facilities available for adequate care, and most importantly, the predictability of an adverse outcome. Now realize that Medicare makes its decision for level of care based on presentation. What is the condition at the time of presentation, where lately the commercial payers are making their decision based on outcomes. Therefore, you can have a very sick patient arrive that in the Medicare world would be an inpatient, but because of the commercial payer, they want to see if they got better and how quickly. These areas for high quality clinical documentation are found in several areas. Number 1, an earlier than expected discharge. When we guesstimate that the patient needs to stay 2 midnights and they get discharged earlier than expected, a reason for that needs to be stated, not just something as simple as, oh, the patient wanted to go home, which sometimes results in these one-day stays. It's important, again, whenever there's a status order change from inpatient to observation, which is actually condition code 44, which we'll be going into in another presentation, or from observation to inpatient. Why did that patient qualify for inpatient at that point in time? And that has to do with patient acuity. As I mentioned, condition code 44 will be discussed in a later presentation, but there also should be something that the physician states that there is a need for an inpatient level of care, and sometimes one might want to add, although it's considered somewhat dangerous to add this statement, and these services could not have been provided in a lesser level of care. So let's talk about the assessment and plan, which I believe is probably one of the most important areas of a history and physical. Many years ago, I came up with a very simple 4 guidelines, actually 4.5 guidelines, to help with the documentation of acuity, and these are easy to remember. Suspects, concerns, predictable risk, and intent for treatment, and the word because, which I'll describe a little bit later on. So suspect, what do you suspect is going on with the patient? Concerns, do you have a high or low level of concern for what can go wrong? And how predictable is that concern? And then what is your intent for treatment? It's also important many times to put down why does or doesn't this patient need an inpatient level of care? And most importantly, what is the plan? This documentation should be done initially, every day, and every time there is a status order change. So let's talk about these 4.5 guidelines in a little more detail. So suspects, what does the physician suspect? It's actually your differential diagnosis, but they must be diagnoses that are pertinent to the case as it stands and as it has been documented. And I will say that if you have high levels of concern for highly predictable events, those patients tend, keyword tend, not 100% of the time, tend to be inpatient. If you have low levels of concern for low predictable events, those patients tend to be observation. Now, if you are admitting a patient for a workup with an unknown diagnosis or even for a known diagnosis, most of the time, those workups tend to be observation. Lastly, the intent for treatment and the expectation that that patient will cross 2 midnights. Now realize that crossing 2 midnights is a traditional Medicare thing right now, but eventually is expected to be a requirement from all of the commercial payers. You may say to yourself, does that mean that I need to be aware of the payer for every patient? Somewhat, yes, but we can discuss that later at another time. Now, the half a guideline is the word because, and that's important because it serves as a nice transition word. I am admitting this patient as an inpatient because, I am ordering this test because, and it can be used frequently in other situations. It is an important qualifier. So now let's take a look at some documentation examples. I only have a couple, but I think one of them is very important and will actually provide a good example for how the documentation should be, taking into account these 4.5 guidelines. And this actually can serve as a good template for you to use, and you may also want to use it in some way, shape, or form for each element of a problem list. So inpatient, outpatient observation level of care is warranted for this patient because he or she presents with, what are your suspicions? And I have a high or low level of concern for diagnoses, not symptoms. Next is he or she is at high or low risk for, and talk about those predictable risks. And lastly, what is your plan of care, treatment, and what does it include? And it must include intent for a 2-midnight stay in most situations. So let's operationalize this, if you will, in a real example. So we have a patient that had a fall at home with hip and rib pain. The patient is a 90-year-old female with a complaint of a fall at home and rib pain. According to the family, the patient fell in the bathtub and hit her left side. She's unable to ambulate after that fall. She's been on oral Levaquin for treatment of a urinary tract infection according to her PCP. She does get unsteady and weak when she has a urinary tract infection per the family. In the emergency room, the x-rays showed a left-sided rib fracture 7 to 11. No hip fracture was noted, but the patient has uncontrolled pain, so she needs IV pain medication for pain control. Past medical history is significant for AFib, congestive heart failure, COPD, CVA, and hypothyroidism. At the time of the exam, the patient is resting comfortably. Most nonverbal at baseline due to dementia. And a lot of this information was gathered from the daughter who would like nursing home placement. Now, there are a couple of areas in this HPI that are concerning to me. The first one is the statement that the patient has uncontrolled pain, so she needs IV pain medication, but a sentence later that says that the patient is resting comfortably. Well, that's a contradiction. What it should maybe say is that the patient is resting comfortably after adequate analgesia. And the last thing is, would like nursing home placement. That raises the question of, is this really because of acuity of the patient, or is this because we want to send the patient to a nursing home eventually? So in the assessment and plan for this patient, the assessment just talks about principal problem being multiple fractures of the ribs and left side. Active problems include some of those things from the past medical history. The plan is a 90-year-old female with left-sided rib fractures, status post fall at home, has been recently treated for a UTI and gets weak and steady with a urinary tract infection. And then the fall at home with left-sided rib fractures, admit for pain control and possible placement. And lastly, the UTI, continue oral Levaquin, etc. Well, needless to say, this documentation does not define the acuity with which this patient presents in order to justify an inpatient level of care, and could easily have been said that these services could have been provided at a lesser level of care. So now let's take that same information and see, using the template, how it can be rewritten or redictated, if you will, in order to define the acuity. And I apologize for reading this while you're reading it also, but it's in order to help bring it to the forefront. So for the assessment and plan, inpatient is appropriate for this 90-year-old female who fell in a bathtub, sustaining multiple left rib fractures. Risk factors include failure of outpatient management of a UTI with oral antibiotics, dementia, unsteadiness, and weakness, which typically occurs with a UTI and leads to a fall risk. And I have a high level of concern for this UTI resulting in a significant injury, as this patient is at risk for sepsis due to a urinary tract infection. Additional risk factors include an elevated white count, elevated temperature, advanced age, which is very important, pulmonary complications due to lack of pain control, and COPD. Plan of care is easy enough. It includes everything that has been mentioned above, and anticipating a 2 midnight stay. And this is an option whether to place it in the assessment and plan, but possibly stating these services could not have been provided in a lesser setting. Another very simple documentation example, and it's not that I'm picking on the orthopods, but this is what is typically seen, although many of their procedures have been taken off the inpatient-only list now and are considered appropriate only for outpatient care. But impression, osteoarthritis of the left hip, plan, left total hip replacement. That's adequate in today's world since these procedures have been taken off of the inpatient-only list, but there are occasional joint replacements that are appropriate for an inpatient level of care, although rare. Let's talk a little bit about a discharge summary, because that also is a very important document, because as this states, a discharge summary should contain a sufficient level of information to ensure that both patients and other healthcare professionals are aware of the relevant events of a hospital admission. And some of the things that they should include are a final diagnosis, both primary and secondary, what was the hospital course, discharge meds and discharge plan, and one thing that's not mentioned very often, but a statement that says the patient is stable for discharge. That's very important from a readmission point of view and sometimes from a medical legal point of view. Just as a quick reminder, the principal or primary diagnosis is the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. Secondary diagnoses are the other conditions that were either present on admission and directly affect the care given for this visit or developed as a direct result of the primary diagnosis. So in summary, these are the 7 C's of documentation that I found from JBH Solutions, and there is the link as to where this came from. But quickly, the 7 C's of documentation include complete, concise, correct, clear, codable, consistent, and compliant. And I think these 7 words are self-evident. So in conclusion, this is the contact information in order to get a hold of me if you have any questions or comments. Thank you for listening.